Hello, my name is Mark Waweru. I'm a fourth year medical student. Uh, I'm here working with Dr. Giro for the course of primary care diagnostic imaging. And I had an interesting case of a patient who had symptoms of radiculopathy as well as upper motor neuron signs, and that's what I'm going to talk about today. So the patient is a 52-year-old African American female who complains of neck and lower back pain. She says neck pain is about 9 out of 10 on pain scale and is associated with right upper extremity pain and tingling sensation extending into the third, fourth, and fifth digits of her right hand. Patient has previously complained of left shoulder pain and exhibited left arm weakness. She denies pain in the left shoulder during this visit. Lower back pain is also rated at 9 out of 10 and is associated with tingling and numbness in lower extremities bilaterally. She also has bowel and bladder incontinence. I'll talk a little bit about that later. So she also says that she can only lift very light weights and has difficulty bending or squatting. So this patient has an extensive history of neck and lower back pain. She began having back pain in 2012 while working as a certified nursing assistant. In July 2000, So while working, she had to stop working because she fell, and so she had to stop working. And then right after that incident, she underwent anterior discectomy and fusion of C3, C4, and C5 for the anterior approach. Again, we do have imaging for that. I will show that later. After the surgery, she began physical therapy until about 2 years later, and she does report that after the therapy she could walk better, and she says she had no falls at all. So about a year later, she was allegedly involved in a motor vehicle accident, and the way she describes it is that the car she was in was struck on the driver's side by another vehicle, and she heard her neck snap and became dizzy and faint. She denies losing consciousness or any blood loss. She, however, began having persistent neck pain, headaches, tingling sensation in left upper extremity, lower back pain, and pain in the lower extremities bilaterally. She also reports loss of urinary control following the motor vehicle accident. So she was told that she had sustained a whiplash and was started on physical therapy at a frequency of twice a week. She does continue going for physical therapy. So in review of symptoms, she does report morning headaches associated with photophobia, phonophobia, nausea, and blurred vision. She also reports loss of appetite, dizziness, insomnia, and weight loss. She denies fevers, chills, or night sweats. Her post-medical history is significant for high blood pressure, for which she takes hydrochlorothiazide. She also takes naproxen, cyclobenzaprine, and iron pill. As far as her physical exam, she's 5'6" tall and weighs 310 pounds. Her blood pressure is 154/74. For her musculoskeletal exam, so we're going to begin with active range of motion of the cervical spine. Flexion is about 23 out of 50, extension 18 out of 60 degrees, left rotation 35 degrees out of 80 degrees, right rotation 40 degrees out of 80 degrees, left lateral bending 25 degrees out of 45 degrees, right lateral bending 15 degrees out of 45 degrees. And with this range of motions, she does report neck pain except when she's flexing. Active range of motion of right shoulder, elevation 90 degrees with pain, and also she has a positive Neur's, Hawkins, and supraspinatus test on the right shoulder. The active range of motion in the left shoulder is within normal limits. Active range of motion of thoracic spine, flexion is 3 degrees out of 30 with pain between shoulder blades. Active range of motion of lumbar spine, flexion is 16 degrees out of 60 degrees with numbness and tingling bilaterally. Left lateral bending 7 degrees out of 25. Right lateral bending 7 degrees out of 25. Extension 4 degrees out of 25 degrees. And she does report numbness and tingling with this range of motions. Her muscle strength is 4 out of 5 in the right biceps, triceps, and deltoid. Grip strength of right hand was 5 pounds and 25 pounds in the left hand. Her right flexor hallucis is 4.4 out of 5. She's able to rise on both heels but unable to arise onto her toes. She did demonstrate right dorsiflexor weakness. Her neurologic exam, her cranial nerve 1 to 12 is within normal limits. Her reflexes, biceps and triceps were 2 out of 4 bilaterally. She had a positive Hoffman's and terminus reflexes in the right third finger. Her patellar reflex was 2 out of 4 bilaterally. Achilles was also 2 out of 4 on the left and 4 out of 4 on the right. We also did a clip weld procedure that showed a sustained clonus in the right foot. Sensation is intact to light touch on upper and lower extremities bilaterally. For the straight leg raise test, right leg raises to 24 degrees with low back pain radiated to lateral aspect of foot. Left raises with localized lower back pain. Palpation of the back, we noted a muscle spasm over the lumbosacral region paraspinally. So the electrodiagnostic findings of upper extremities showed no evidence of cervical plexopathy, focal upper extremity entrapment, neuropathy, peripheral polyneuropathy, or myopathy. Basically, the EMG and nerve conduction studies were normal in the upper extremities. For the lower extremities, she was found to have active right and left L4 to L5 radiculopathy. So we did obtain images of her cervical spine and lumbar spine. So in this figure, we see a bone window of CT reconstructed images with a midline sagittal view and axial cut through C2 to C3. So here you can see a small central bulge of the annulus with mild secondary stenosis. The foramina are patent. Again, like I mentioned, she had a surgery to her neck, and this is where between C4 to C6. That's where the discectomy and the fusion of the vertebra was done. This is a soft tissue window of the same C2, C3, and again you can see the same findings. This is a bone window CT reconstructed image with midline sagittal view and axial cut through C3, C4, and here you can see a broad-based disc osteophyte complex with stenosis and findings suggestive of mild secondary canal stenosis. So here, findings suggesting impingement on the ventral cord. Right there, and right here as well. This is the same as C3, C4 soft tissue window with the same findings. This is a bone window CT of C4 to C5. Again, you can see there is anterior discectomy and fusion with instrumentation. There is encroachment with stenosis and impingement on the ventral cord. There is also bilateral foraminal stenosis right there. So this is C3, C4 over a soft tissue window, and you can see that there is impingement on the ventral cord. There is also bilateral foraminal stenosis. This is a bone tissue window. Reconstructed images with midline sagittal view and axial cut through C4 to C5. There is anterior discectomy and fusion with instrumentation. There's also stenosis, spinal stenosis, and impingement on the ventral cord. There's also bilateral foraminal stenosis. This is a soft tissue at the same level, C4, C5, and again with the same findings. This is a bone window CT reconstructed images with midline sagittal view and axial cut through C5, C6. Again, you can see anterior discectomy and fusion. There is impingement on the ventral cord and bilateral narrowing with more stenosis on the left. This is a soft tissue window at the level of C5, C6, again with the same findings. This is a bone window CT that shows mild stenosis of the foramen bilaterally. Again, this is a soft tissue window at the level of C6 to C7, showing the same findings as before. This is a T2 weighted MRI image with midline sagittal view and axial cut through L2 to L3. There's very mild asymmetric left lateral bulge of the annulus and a mild encroachment upon the left foramen without effacement of the L2 nerve root. This is a T2 weighted MRI image at the level of L3, L4. Again, there is bilobed bulge of the annulus that is greater on the left than right. This is a T2 MRI image at the level of L4, L5. Again, there is a broad bulge of the annulus with marked facet arthropathy. There is also bilateral foraminal stenosis with compression of the L4 nerve root bilaterally. So you can see that. Again, this is a T2 MRI image at the level of L5, S1. There's a mild diffuse bulge of the annulus with marked facet hypertrophy. There's also bilateral foraminal stenosis and effacement of the L5 nerve roots bilaterally, greater on the left than the right. This is a T2 MRI image with midline and sagittal view and axial cut through C2 to C3. There's a small central disc bulge. This is a T2 MRI through C3, C4. Again, you can see spondylosis and disc space narrowing. There's also ventral osteophytes. And bilateral foraminal stenosis. Again, you can see there's impingement on and flattening of the ventral cord with associated spinal stenosis. This is a T2 MRI image through C4, C5. Again, you can see anterior cervical discectomy and fusion. There is also mild central spinosis and spinal myelopathy. This is a T2 image through at the level of C5, C6. You can see anterior cervical discectomy and fusion. There's also foraminal stenosis bilaterally. MRI image, T2 MRI image. Again, it shows narrowed disc space with disc desiccation and broad-based bulge effacing the anterior subarachnoid space. Again, here we see a ventrospinal cord impingement. This is a T2 weighted MRI image with midline sagittal view and axial cut through the brain. So here you can see multiple foci of hyperintensity identified through the white matter. So here the largest abnormality is left parietal, measuring is in the left parietal, measuring 1 centimeter in diameter. There's a linear appearing lesion within the right corpus callosum right here, which suggests the possibility of demyelinating disease. Again, this is a T2 weighted MRI image. This is more right side. This is the more right side of the brain, just to kind of show where the lesions are. So the differential diagnosis for these findings include upper motor neuron disease, cervical radiculopathy, shoulder impingement syndrome, and lumbar radiculopathy. So the final diagnosis was cervical spinal stenosis and myelopathy with lumbar radiculopathy. So, and this was confirmed with the MRI of the brain, the MRI of the cervical and lumbar spine, as well as upper and lower electrodiagnostic studies. So, treatment and follow-up for this patient, as reported in the HPI, patient had has had back pain since 2012, treated with surgery that involved anterior discectomy and fusion of C3, C4, and C5. She was also treated with physical therapy and other conservative measures. After the accident in 2016, she was treated with chiropractic manipulative therapy. She has also received ultrasound therapy to the cervicothoracic region, and she was also encouraged to apply and increase quantum exercise to strengthen the lower back and core. She's been taking cyclobenzaprine and naproxen for pain. She'll continue with physical therapy and following up with the chiropractor. So this is an interesting case of a patient with both upper motor neuron signs and cervical as well as lumbar radiculopathy. The symptoms suggestive of cervical radiculopathy include neck pain associated with right upper extremity pain and tingling sensation extending into third, fourth, and fifth digits of right hand. And symptoms suggestive of lumbosacral radiculopathy include lower back pain associated with tingling and numbness in lower extremities bilaterally. Signs for this patient that suggest upper motor neuron lesion include positive Hoffman's and Trommner's reflexes in the right third finger, brisk Achilles reflex on the right lower extremity, sustained clonus, and Babinski's sign in the right foot. So given these findings of upper motor neuron lesion signs, and radiculopathy symptoms, one would expect that this patient would have multiple lesions in the brain and spinal cord or entirely in the spinal cord. This is because neurologic abnormalities resulting from upper motor neuron lesions occur contralaterally when the lesions are located superior to the spinomedullary junction, and ipsilaterally when the lesions are located caudal to the spinomedullary junction. So for this patient, assuming that the location of upper motor lesion is in the brain, and given that this patient is exhibiting upper motor neuron signs on the right side of her body, it is expected that the lesion would be on the left side of her brain. The MRI image that I mentioned earlier showed a significant lesion within the right corpus callosum, suggesting suggesting the possibility of demyelinating disease. This patient, however, lacks typical signs and symptoms of demyelinating disease, such as impaired vision, ataxia, and paralysis. The lesion itself is also not, so right here, the lesion itself is also not is not a typical demyelinating lesion. It is therefore unlikely that there is an upper motor lesion in the brain. So the other possibility is an upper motor neuron lesion in the right side of the cervical spinal cord. And this is kind of what we thought she has. So imaging of the cervical spine did confirm impingement on the ventral cord and bilateral foraminal stenosis at the level of C3 all the way to C6. Spinal myelopathy was also noted at C4 to C5 disc space. And these findings are therefore likely to be the cause of the upper motor neuron signs. There have been studies that show lesions occurring on the ventral aspect of the spinal cord at the cervical and thoracic levels result in abdominal muscle weakness. And this is because about 20% of the upper motor neuron fibers, specifically the anterior corticospinal tract fibers, do not decussate at the spinomedullary junction to the contralateral side. They rather descend in the ventral portion of the spinal cord and innervate the anterior and posterior abdominal muscles. This patient, however, has signs of upper motor neurons lesion primarily on the right side of her body, and also she does not have abdominal muscle weakness. So the reason I'm bringing this up is because just to show that it's unlikely that the anterior corticospinal tract fibers it's unlikely that the anterior corticospinal fibers have been damaged, since she doesn't have any abdominal weakness. As far as her cervical radiculopathy symptoms, the electrodiagnostic testing was normal. Electrodiagnostic testing of the upper extremities was normal. And that leaves us with the imaging of the cervical spine, which did confirm impingement on the ventral cord, bilateral stenosis at the level of C3 to C6, and there was also some degenerative changes such as disc desiccation and broad base bulge facing the anterior subarachnoid space. So these findings again could explain why she has the cervical radiculopathy symptoms. Now, although the patient states that she could walk better and her symptoms improved after the neck surgery and going for physical therapy, it is not completely clear whether the apomotor neuron signs were present after or prior to the accident in 2016. However, on the CT and MRI of the cervical spine, which I showed earlier, we see impingement on the ventral cord and spinal myelopathy at C4, C5, and these are likely to have resulted from anterior discectomy and fusion with instrumentation. So it is therefore likely that the cervical radiculopathy as well as the upper motor neuron signs that she has resulted from the neck surgery in 2012 and only became apparent when she presented to the chiropractor's office. As far as the the lumbar, radiculopathy, the electrodiagnostic studies did confirm active right and left L4 to L5 radiculopathy, and the imaging of the lumbar spine at L4, L5 showed a broad bulge of the annulus with marked facet arthropathy. There's also bilateral foraminal stenosis with compression of L4 nerve root bilaterally. And these findings can explain why she has lumbar radiculopathy. Also, we can see that the electrodiagnostic studies did confirm active alpha L5, and this is likely from the accident that she had in 2016. So a little bit about the surgery, neck surgery, and as a treatment option for back pain or neck pain. There was a study that compared surgery and conservative treatment, and what they found was that patients who undergo surgery reported faster relief of symptoms than patients treated conservatively, but overall improvement of symptoms in both groups was equivalent at 1 or 2 years. So this patient is currently being treated conservatively with physical therapies, cyclobenzaprine, naproxen, and chiropractic manipulative therapy. Other studies have, however, shown that patients with compressive radiculopathy, about a third of patients with compressive radiculopathy do experience recurrence of symptoms after the initial improvement. So it's likely that this patient may continue having radiculopathy symptoms even while being treated with conservative measures. Moreover, this patient has factors which places her at risk for radiculopathy, including her female gender, obesity, degenerative changes seen on her MRI spine, and history of heavy and frequent lifting as a certified nursing assistant. The presentation of both upper and motor neuron science and radiculopathy is certainly an interesting topic and raises a question about whether a single lesion in the spinal cord can cause both upper motor neuron signs and radiculopathy symptoms. Um, the the other question is whether there's a summation of these symptoms, of these signs and symptoms of these upper motor neuron signs and radiculopathy symptoms. For example, just as an example, this patient had hyperreflexia, Achilles that was 4 out of 4. Um, so if both radiculopathy and upper motor neurons lesion were present, the presentation of both upper motor neuron signs and radiculopathy is certainly interesting and raises a question about whether a single lesion in the spinal cord can cause both upper motor neuron signs and radiculopathy symptoms. If a single lesion can cause both upper motor neuron signs and radiculopathy, then the other question would be what effect would uh, th- that have on the stretch reflexes? Would the stretch reflexes be brisk, normal, decreased, or absent? And in order to answer these questions, future studies should investigate the exact role of upper motor neuron fibers in the mechanism of hyperactive stretch reflexes.